Okay.
So thank you everyone for being patient. We had just a small technical glitch. My name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders, and I will be your organizer for this evening, and would like to welcome you to our webinar on medication management of Tourette syndrome and co-occurring disorders. Thank you all for joining us. Before I introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Heard answer the questions at the end of her presentation. We will get to as many queries as time allows. And in addition, tonight's presenter is available to take your questions on the Wednesday webinar blog that is found on our homepage under the heading Program. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill out the survey as you exit your webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Tonight, we are welcoming Dr. Takijah Heard to our webinar family of presenters. Takijah is a pediatric neurologist and epileptologist that attended Harvard for her residency, fellowship, and classes towards her master's degree in public health. Dr. Heard earned her medical degree at the University of Chicago Pritzker School of Medicine and completed her residency in pediatrics at the University of Illinois Hope's Children Pediatric Residency Program. Dr. Heard evaluates and treats patients with a variety of neurological and neurobehavioral concerns, including but not limited to autism, ADHD, Tourette syndrome, neuropsychiatric disorders, and epilepsy with a particular expertise and interest in epilepsy. Dr. Heard is passionate supporting causes related to pediatric health, especially in underserved communities. Welcome, Dr. Heard. We look forward to your presentation.
All right. Hi, everybody. Again, we are here to learn a lot about the medication management of kids with Tourette syndrome and its co-occurring conditions. Again, my name is Takijah Heard, and let's go ahead and get started. So, questions. What are going to be some of the signs and symptoms of Tourette syndrome? What are going to be some of the co-occurring conditions of Tourette syndrome? How can we manage and treat these patients with Tourette's plus syndrome? And how do you decide when to treat Tourette syndrome? So those are going to be the questions that we're going to discuss today. And as we sort of move through the presentation, I wanted to make sure that we had sort of a little bit of a format in regards to the objectives. So here we'll learn a little bit about the epidemiology of Tourette's, types of vocal tics and types of tics in general, definitions, characteristics of Tourette's, diagnoses, prognosis, screening, and then management. We'll spend a lot of time on the management, and then we'll sort of quickly pop into society and culture. So going through, when we talk about the epidemiology of Tourette's, Tourette's is something that happens in 1 in 5 school-age kids. So this is about 20% of kids may have tics at some point in time in their career or anytime during their school-age years, but may not persist. The combination of having both tics and Tourette syndrome occur in about 1% of the population. So 1 in 100 school-age kids will end up having Tourette's or tics. It is estimated that over 50% have Tourette's or tics but go undiagnosed. In general, Tourette's affects all ages, ethnicity groups, and races, but happens to affect males a little bit more often than females. So this is in a 4-to-1 ratio. So it happens to affect boys a little bit more so than girls. Whenever we talk about tics, a lot of people sort of use the word, but these are some of the definition that goes along with it. When we talk about motor tics, these are movements that happen to occur, and it usually sort of starts in the face. You'll sort of start to notice that somebody sort of may blink very often, have some facial grimacing, maybe some jaw movements, some head bobbing, jerking, and shoulder shrugs. And the way that they're presented here is sort of the way in which they present. They usually sort of start in your face, at the upper portion of your face, maybe with some eye blinking, eye rolling, maybe some eyebrow raising, and then sort of come down. As they come down to your voice box, it's usually whenever you start to have the phonic or the vocal tics. And this is where a noise is produced. Sometimes you sort of remember whenever we talk about Tourette's in the media, oftentimes people sort of recognize that there's coprolalia. That's not a common occurrence of Tourette's. Oftentimes it's a small noise that's not very forceful or purposeful. So it may be a sniffle or a grunt or maybe a clearing of the throat, but it's not ever that purposeful as the clearing of the throat that I just did. It's more of a So those are some of the things that comes along with the vocal tics. Sometimes the vocal tics can become complex, equal to the motor tics. Just like motor tics can sort of turn into things that happen in your arms and in your neck, the vocal tics can become a little bit more complex and sort of can lead to the production of words. Chirps, whistles, grunts, growls are some of the common ones that many people may experience. Going through, after we identify what are the different types of tics, whether they're motor or vocal, how do we get these diagnoses that we as physicians oftentimes use? So we have transient tic disorder, chronic tic disorder, and Tourette syndrome. And so as you can see here, I try to do what I can to highlight the time and what is present. So here it's either going to be a motor or a vocal tic that lasts for about 6 months. A chronic tic disorder is going to be a motor or a vocal tic that lasts for greater than a year. And then Tourette syndrome is whenever you have at least 2 motor tics and a vocal tic that lasts for over a year. It doesn't make a huge difference in the type of motor tic, just the presence of 2, and the type of vocal tic, just the presence of 1. But this has to happen for a total of a year. As we go through, Tourette syndrome is a hereditary neurodevelopmental disorder that affects children. Hence, pediatric neurologists like myself usually will take care of these kids, and then they can go into adulthood, but we'll talk about that a little bit more when we get to prognosis. The tics are sudden, uncontrollable. So these involuntary movements are something that they cannot fully remove. It's very similar to how we breathe and how we blink normally. The movements are sudden and happen sort of relatively frequently. So again, as we sort of spoke, the motor tics are 2 or more, and they usually will cycle or change, and at least 1 vocal tic or a phonic tic, and that will again will sort of cycle or change. And it happens to be something that sort of waxes and wanes. So there may be times in which you notice that the vocal tics and the motor tics will become very, very apparent and very frequent. That frequency may sort of depend on emotion. So if we are excited or emotional about anything, whether that is a good emotion, anxious and excited about a birthday party, or upset about to be reprimanded by, you know, sort of a parental figure, you'll sort of notice that those tics may come out a little bit more. And that sort of may happen for, you know, maybe for 3 weeks that you'll notice the motor and or vocal tic sort of persistently, and then it'll sort of go away for 3 months, and then it may sort of come away, go away for 3 seasons, and then come again for 3 days. So that's the waxing and waning sort of frequency that I'm sort of speaking about. It comes, and just as quickly as it comes with those sudden movements, it'll go just as suddenly away. As I said, as a pediatric neurologist, it has to have this onset before the age of 18. Those are the characteristics of Tourette syndrome, is that it has to have those characteristics that usually gives us that final diagnosis. And tics can happen, these sudden movements can happen for multiple reasons, but generally it has to not be caused by a substance or any other medical condition. Okay, so then when we were talking about diagnoses, so genetically, it can be associated with a few genes that we've identified, and it does have a hereditary component. So we find that about 47% of patients with Tourette syndrome have a positive family medical history of Tourette's in their family. And sometimes of those, 25% of patients that have a positive family history of Tourette's, it happens to be in both parents. So of those that have Tourette's, 25% of those kids will end up having both mom and dad with that feature of having both a couple of motor tics and a vocal tic lasting for about a year. But there's no true diagnostic test. When we think about coming to a medical professional, we think about, oh, okay, is there a lab that can sort of give me that diagnosis of Tourette's? Is there some type of imaging study? Would I need to do an MRI? Do I need to do a head CT? Is there some type of EEG or sleep study that goes along with that? And the answer is no. Oftentimes we'll find this information during the history. So as the parent or the person is coming to tell me a lot about the story as to when it began, how long it's been, what are the tics that they notice, that's the diagnostic criteria. As we move a little bit further, I'll give you some additional unique characteristics that let me know that this is Tourette's and not some of the other things like myoclonus, tremor, chorea, dystonia, akathisia, dyskinesias, Bothersome, or epilepsy. So it's a couple of things that sort of uniquely let me know that this happens to be Tourette's, which is more of a neurobehavioral illness that has some sequelae that may require some treatment versus some of these other things that sometimes can lead to another developmental issue or neurologic issue that have some additional types of management. So here's what I was talking about. These are the unique diagnostic criteria for Tourette's. They usually will have an urge, and some people may not know what an urge is. So an urge is what I consider to be something that is a little bit of a tickle right before the movement happens. So I oftentimes will tell my patients, right before you sneeze, there's this funny feeling. What is that funny feeling? That's the urge to let you know you're about to sneeze. It as well is a sudden movement that sort of happens. Usually it's sort of preceded by a reason, but that sort of funny feeling that you have right before is the urge. It lets you know to sort of protect yourself, cover your face, and sort of protect others from the sneeze that's going to ensue. Those that have an urge oftentimes can do some of the other things that we'll talk about a little bit later. Another unique characteristic for Tourette's is the suppressibility. And just like you can suppress a sneeze, this is something similar. You can also suppress some of these vocal tics. Regardless, it's going to happen, but it happens not to be as loud, as obvious, and you can suppress it to where it's a little bit more subtle. Vocalizations, many of the things that I just sort of spoke about from a neurologic perspective, epilepsy, tremors, myoclonus, Bothersome, chorea, they usually don't come along with vocalizations. Those are usually movement disorders that don't have vocalizations that comes along with it. And then usually the other thing that sort of goes along with Tourette syndrome is that it's present only in the awake state. These sudden movements and changes happen whenever you're in the wake state only. Some of those other movements will happen whenever you're falling asleep and or sleep, especially epilepsy, for example. And then if I don't sort of pick this up during the time in which we are together and you're telling me the history, and it happens to be a waning period, videos are always helpful. So if this is something that you're sort of worried about in your loved one or in your child, then try to take a video of it and then bring that to the physician whenever you have the opportunity. And oftentimes we can tell a lot by just reviewing the video. So prognosis for Tourette syndrome. We've sort of talked a little bit about this as a pediatric neurologist. The onset is in the pediatric age group. It has to be before the age of 18 for it to be Tourette's, but usually the onset is relatively young, usually as they're sort of approaching school age, so between 5 and 7 years of life. And usually the initial tic, as I said before, sort of starts in the head and the face. Usually the most common one is eye blinking. Sometimes it's missed, and people may sort of recognize it as sort of a facial grimace of some sort that may sort of be the beginning of awareness of the tic. But eye blinking and eye rolling are the more common sort of initial tics. The peak in frequency is usually as they sort of reach and approach the double digits. So usually between 8 and 12 years of life, you can sort of notice that there's going to be a peak in the severity and the frequency of the tics. And it can range anywhere from mild to severe. So obviously the more severe and the more obvious the tics are, the more likely it is they're going to be recognized. Many times these improve by late adolescence. So usually the tic freedom may arise as they're sort of becoming a teenager, and sort of as they're coming out of pediatric care, they sort of may notice that the tics go away. If that happens to be the case, that's great. But if not, then sort of lead into our adult colleagues in neurology to continue to treat them. And then some people, as we all know, continue to have tics that persist through adulthood. And if the later the tic sort of initiates, sometimes they sort of can have more severe tics, more refractory tics, more difficult to treat tics. And oftentimes that's whenever we sort of result in some of the additional treatments that we'll talk about a little bit later. So, as I said, tics can range from mild to severe. And whenever I sort of say severe, this can sort of initiate into self-injurious and debilitating behavior. So whenever I talk about self-injurious, sometimes I've had a couple of kids that sort of move sort of further back, and oftentimes their shoulder movements sort of cause them to have bruises. Sometimes the flailing of their arms and their limbs sort of causes them to hit other things, thereby causing it to be self-injurious. The debilitating manner of Tourette's in general is where the management sort of piece comes in. Debilitating is sort of anything that happens to affect their activity of daily living. And we'll talk about that in a little bit more detail when we get to management. So as I sort of rolled a little bit closer to getting to management, it's many things that we're sort of looking at to gauge the management is understanding the types of tics that we have, the frequency of the tics that we have, and the severity. And these things will regularly cycle. So the type may sort of change from a motor tic to a vocal tic. The vocal and or motor tic may change. The frequency may be something that you just sort of notice maybe in the morning or whenever they're tired. They tend to happen a little bit more frequently whenever there's some sort of bodily stress. That could be emotional stress, that could be sort of environmental stress, that could be stress caused from illness, that could be stress caused from sleep deprivation. And sometimes the severity of the tics will change based on those things. And so those external and internal factors are the things that sort of make them happen a little bit more frequently during the waxing period. So screening for comorbidities. So this is where the treatment sort of starts to come in, and oftentimes the things that may sort of affect their ability to function and not have any changes in their activity of daily living. So people with Tourette syndrome often have other mental or behavioral or developmental conditions that may be present prior to the onset of tics. And oftentimes we notice that about 80% of people are diagnosed with at least one of these additional conditions. So as I diagnose Tourette's, I'm oftentimes asking and looking for these other conditions. So these comorbidities, the most common co-occurring condition is ADHD and OCD. One thing that I would like for you to all to sort of recognize is that they are oftentimes acronyms. And so the alphabet soup of TS, Tourette syndrome, sometimes comes with more frequently ADHD and OCD behaviors. And so those are sort of the cornerstones in which I start to ask questions once I have diagnosed Tourette's in one of my patients. So what is ADHD? Problems concentrating, focusing, and impulse control. What is obsessive compulsive disorders? It is repetitive or unwanted intrusive thoughts and repetitive behaviors. Again, these are the impulse to repeat these routine rituals. And so I'm hoping that you sort of recognize that impulse is sort of a piece of all three of these that make them have that commonality. Other screenings and other comorbidities are behavioral, so sometimes oppositional defiance, socially inappropriate behaviors, impulsivity, again, as mentioned, rage, aggression, anxiety, so generalized anxiety disorder, GAD is another acronym, sort of going along with the alphabet soup that can come along with Tourette syndrome. So just a worrier or worrywart, somebody that has excessive shyness, separation anxiety, fearfulness. Sometimes these kids can also have learning disabilities in reading, writing, mathematics. That has nothing to do with their intelligence. Their IQ may be appropriate, but sort of sometimes may have some learning disabilities that may associate with it. Social skill deficits and social functioning. They may have some difficulty developing social skills and dealing with family members that may be not age appropriate. Sensory processing issues, having some changes with sensitivities to all of the senses, sense of sound, touch, taste, smell, and then sometimes they can have trouble falling asleep or staying asleep. So management. So I just wanted to make sure that we had that history and that background, that foundation about Tourette syndrome before we start talking about the management of Tourette syndrome. So now that we've had the diagnosis of Tourette syndrome in our heads, we sort of know what the definition as well as the vocabulary that goes along with Tourette syndrome. Just sort of want to talk about what can we do in regards to the management of Tourette syndrome. And as we sort of talk about the management, we sort of want to mention here that sometimes management is time, and time may sort of exist in not doing anything, allowing the wax to sort of turn into a wane and just allow time to allow it to go away. Outside of that, we do have behavioral therapy, we do have medication management, and then surgical interventions. So here I'd like to spend a little bit more time and sort of talk about a couple of patients and sort of as we sort of go through our Tourette's clinic. So welcome to Tourette's clinic. Here we have a little boy, his name is Everett. Again, he's a boy because it happens a little bit more frequently in boys. He is now 14 years of age, and so at an age in which he has been dealing with Tourette since he was 12. He's presenting with an increase in his vocal tics with a chirping after illness that he had, and the illness has been going on as well as the chirping has been going on for the last 2 weeks. And he feels them a moment prior to the chirp. And so here I just sort of wanted to highlight several things. And him, it ended up being that the illness sort of provoked the occurrence of these vocal tics. And then he says that he can feel them a moment before the chirp actually happens with his vocal tics. So what should we do next for Everett? So Everett happens to not necessarily have anything that is wildly bothersome to him. The chirp is something that he can sort of know what happens right before it. And so in my mind, I would say first, do no harm. So watchful waiting is a appropriate treatment mechanism for those that sort of have a vocal tic that happens to be simple, that happens to not be bothersome. So nothing actually happens to be a treatment. And so how do I choose that? Oftentimes I'll choose that based on a few factors and seeing how it affects them behaviorally. And so when can we use something called habit reversal therapy? It's whenever you're able to identify an urge. And remember with Everett, he said that he's able to identify the urge of, or the sort of a funny tickle right before it happens. So he's able to identify his urge. And so oftentimes we'll use something called habit reversal therapy to combat the involuntary movement, which is the tic. And for him, it's a vocal tic, to go along with the voluntary movement where he sort of may decide to push his tongue at the roof of his mouth. He may decide to curl his toes in his shoes, but you sort of combat a involuntary movement with a voluntary movement, thereby canceling them out or making the tic much more subtle. So this would be something that I would use for him because he's of age to sort of control it in that way. He is of age to actually have an urge, and he's of age to possibly be somebody that's involved in habit reversal therapy. So habit reversal therapy sort of teaches awareness. He now has the awareness, and it creates a competing voluntary response, whether that's pushing his tongue up the roof of his mouth, curling his toes, or tensing his abdominal muscles. Habit reversal therapy is a behavioral therapy that is in the umbrella of comprehensive behavioral interventions for tics, CBIT. So it includes habit reversal therapy, that's what the HRT is, as well as relaxation training, functional interventions. And so some of these functional interventions is sort of the pushing up of his tongue, which obviously sort of reduces the likelihood of that chirp sort of coming out. The relaxation techniques will usually sort of decrease the emotional sort of component that comes along with our vocal tics. And then just having some awareness of the environmental triggers, whether that's the nervousness of being around certain friends or certain people. And then usually the CBIT is oftentimes helpful in about 8 sessions. So on average, about 50% have a reduction in their tic severity and improvement in the function of their lives. That usually lasts about 6 months after the completion of about 8 sessions of CBIT. And so oftentimes I'll try to start that off first, mainly as a behavioral therapy, especially whenever they understand their urge or that feeling of that sort of odd feeling that happens right before one of their tics actually occurs. Because overall, our goal whenever we're treating Tourette's from a management standpoint is to reduce the severity and the frequency of the tics. So now let's go back to Tourette's clinic. And now we have a little boy named Peyton. He's a 13-year-old boy with Tourette's, and he's had it since he's been 7. Now at the age of 13, he's noticing that maybe ADHD is a little bit more of a concern. He's doing poorly academically and socially. So why is this important? Oftentimes, I usually like to treat treat ADHD and Tourette's whenever, you like to treat Tourette's whenever it's sort of more of a bother to their activities of daily living, or if it's a possible problem with the quality of life. And so once we start to have poor functionality in their academic days and their social relationships, that's really whenever I feel like medication management should sort of step in. So what should we do next for Peyton? With Tourette syndrome sort of being a behavioral issue, these behaviors are actually sort of causing him not to live to his greatest potential. So let's do something to try to see if we can make Peyton's life a little bit better. So medication management is usually often in my life for my patients, usually whenever it's affecting their quality of life or their activities of daily living. So are they getting bullied because of their tics? They're getting conduct marks at school. Oftentimes this happens a little bit more whenever some of the teachers may not understand, or they're making noises and they feel like those noises are causing them to disrupt class. If it's causing any type of pain or duress. And so that pain and duress oftentimes happen a little bit more with the more severe motor tics. Sometimes it's a little bit more of the complex tics that sort of cause them to have more movements of their shoulders and arms. And so that pain is something that I usually will start medications for, or if it's causing dysfunction to the patient. And so for Peyton, this is truly true for him. It has caused dysfunction to him. And so that is the reason that I would try medication management for him. So whenever we talk about medication management, we have various reasons that we use various medications, and some that are FDA approved and some that are not FDA approved. So in the pediatric world, we find that many medications are considered to be off-label uses versus on-label uses. So whenever I sort of talk about that, you can sometimes look, for those that Google and go online, you can sometimes find like various medications that may be used for Tourette's. In the pediatric world as a whole, regardless if it's pediatric neurology or GI or just as a pediatrician, there are many off-label uses for medications in the pediatric population that you may not see FDA approved use for in the adult population. And a very common set of them are the alpha agonists, Guamfacine and Clonidine. Both of these alpha agonists are off-label uses for Tourette syndrome and tics. So we oftentimes will use these very commonly, well known in the pediatric world for Tourette syndrome. Oftentimes I use Guamfacine or Clonidine, mainly whenever you sort of notice that there is a combination of having Tourette syndrome as well as ADHD, Tourette syndrome as well as impulsivity, Tourette syndrome as well as anxiety, Tourette syndrome as well as difficulty falling asleep. So sort of here, I sort of hit many of the very obvious, very common side effects or comorbidities that come along with Tourette's. And usually my alpha agonists are the ones that I usually start off with. Guamfacine and Clonidine oftentimes can come also as a extended release formulation. That extended release formulation does sort of help with compliance. Again, all of these kids are usually young kids approaching their teenage years. And if we can sort of get them to start on a medication that may be only at night or once a day, it sort of increases compliance. As we all know, we're not going to end up improving the issue unless we're taking the medicine, and the medicines has to be something that we routinely do. And so oftentimes Guamfacine and Clonidine are my first choice, especially whenever it comes down to ADHD and Tourette's, mainly because of the improvement in their compliance when we give it at night, improvement in their sleep when we give it at night, and possible reduction of the side effects when we give it at night. Guamfacine and Clonidine are both well known for possibly causing sedation. So it may work in our favor for those that have sleep issues. It may also work in our favor whenever it comes down to dealing with the nighttime dosing. Oftentimes, I give it at bedtime, and whenever it's given at bedtime, it frequently will result in, by the time they wake, they are no longer groggy or bothered by the possible side effects of sedation. So Guamfacine and Clonidine are initially started with the immediate release formulations given at bedtime, monitoring for AM grogginess or sedation. Oftentimes I'm asking the parents if it is more difficult to wake them up, they have to go to the room more often, they're just sort of moving slower, and then I know to adjust my dose based on those that feedback. You start off at a low dose and then can go up to 4 or 5 times that sort of initial goal dose, depending on effect and side effects. And then Clonidine as well also has a extended release formulation for it called Catapress, and the other name for Guamfacine, whenever it's in its extended release formulation, is 10X. And then going down to the FDA approved medications are the antipsychotics. Usually I'll use the antipsychotics for whenever there's a little bit more of the behavioral piece of it, things that a little bit are more of the OCD behaviors. We'll talk about that with our next patient. Some of the depression sort of issues, some of the issues that come along with anxiety. But I just quickly wanted you to remember some of these names. We'll come back to them whenever we're sort of talking about our next patient. So first generation and second generation, as we sort of talk about medication management, another sort of general overview from a pharmacology sort of standpoint is first generation is the original antipsychotic. First generation tends to be older, sometimes happens to be more effective, but sometimes comes with a lot more side effects that makes it intolerable. So oftentimes the second generation medications are newer, happen to have been produced mainly because they reduce many of the side effects that make them intolerable, and oftentimes are much more tolerated by the patient. So oftentimes the second generation medications are oftentimes much better used and have less side effects that tend to be tolerable. So my sort of go-to second generation antipsychotic happens to be Abilify. But overall, whenever we talk about antipsychotics as a whole, sometimes they can have some side effects that are irreversible or sometimes hard to sort of deal with, one of which is increase in appetite, weight gain, that sometimes can sort of result in a change in their mood, where their moods can be a little bit more flat. Sometimes it can result in more sedation and more drowsiness in comparison to the alpha agonist. And many of those things can sort of result in sometimes sort of long-term side effects of an illness called Tardive Dyskinesia. And so oftentimes I will use some of the antipsychotics in hopes of improving their Tourette syndrome and or OCD behavior, but oftentimes trying to make sure that we're not going to go past to something a little bit more permanent or a little bit more bothersome, like weight gain, that's difficult to address later. So just going to the second line, antipsychotics are those that I'm just sort of reiterating here, making them a little bit bolder because those are the ones that I prefer to use because those second generations tend to have less of those side effects. All right, so let's go back to Tourette's clinic. So now we have Giovanni. So Giovanni is a 17-year-old boy with Tourette syndrome since he's been 8. And he presents with focal facial tics, and this is more of a grimacing that he sort of recognizes that prevents him from reading and walking, and he also has OCD behavior. So Giovanni is somebody that oftentimes have a facial grimace that causes him to almost wink. This winking sort of sometimes frequently happens on one side of his face, but sometimes it will sort of require that it happens in both eyes, thereby sort of allowing him to hold on to his eye closure for a long period of time, thereby causing it to be very difficult for him to read and furthermore just walk, just because he can't see, because sometimes the facial tics get stuck. So this is very debilitating to Giovanni, and sometimes definitely changes his quality of life. Furthermore, he has started to develop OCD behaviors where he has these routine rituals that prevent him from getting out of the house in the mornings. Frequently, his mom wakes him up very early or recognizes that he's awake very early. School's at 8. Giovanni frequently will wake up around 4:30 to begin his washing routine. Despite having taken a bath the night before, he'll wake up at 4:30, sort of clean the entire bathroom, despite having done this the night before, and then have everything in order, clothes are ironed, all of those things, and he has to sort of tap things, turn on lights, and so those OCD behaviors sort of prevent him from getting, 1, a good night's sleep, 2, sort of causes him anxiety if the cleaning materials are not available for him. And so all of those things have sort of led to this quality of life that has been bothered. With that being said, He frequently is late for school. So what should we do next for Giovanni? So botulinum toxin can be used for patients with bothersome focal tics. So botulinum toxin is oftentimes known as Botox, and we sort of can do this in the office where we will inject the muscle group that happens to be most affected. For him, it happened to be a little bit more on his right than it was on his left. So we oftentimes would come to the office and he would get the Botox sort of injected into the muscle groups that are most affected. This can be used to be helpful for the focal tics, and oftentimes will relax those muscles, thereby reducing the focal tics that are quite bothersome, hoping that this will lead to improvement in his ability to read and write and walk and sort of function. So the Botox would be the treatment mechanism that we would use for his focal tics that we find in his face. So sometimes whenever we come from medication management, like we've sort of discussed, we can go to something that is a little bit more dramatic for refractory complex tics. And sometimes deep brain stimulation is something that is used. This is a surgery where we put an apparatus actually physically in the brain. This is a open cranium surgery that we put an apparatus in the brain that sort of targets the movement centers where these tics sort of reside. And then with time, it sort of starts to stimulate. So it's a neuromodulatory mechanism that is used for refractory complex tics. These types of tics are the ones that are very difficult to treat, refractory to medication, refractory to ease and quality of life, very debilitating, and oftentimes will go as far as these types of surgeries that can be helpful. Oddly enough, it would also be helpful for those that also have OCD behaviors. So deep brain stimulation happens to be quite helpful for those that have not only refractory complex tics, but also OCD behaviors. And we found that it's been quite helpful for allowing those people to have less debilitating issues with their quality of life. Now, here is this rubric that I'm hoping that you can see and sort of etch into your brain a little bit whenever it comes down to medication management. And so we sort of talk about starting at the very top. Are there any comorbidities like ADHD, OCD, and other behavioral comorbidities? Again, thinking about the alphabet soup as we sort of review and summarize, ADHD and OCD are the more common of the comorbidities, and the other behavioral comorbidities are also sort of mentioned here. So as we have gone through our Tourette's clinic, our answer was yes for our last two patients. So we can treat the behavioral comorbidity or condition, but we may end up sort of treating the tics first. Whenever we sort of talked about our first patient that also had ADHD, just recognizing that one thing that I wanted to mention is that ADHD can frequently be treated with stimulants, and stimulants can worsen your tics. So that's why I didn't necessarily use the stimulant to treat his ADHD, because it may and most likely will increase their tics. So with that being said, I usually use a non-stimulant option to treat both. And then as we sort of go down the diagram, they say, are the tics mild or severe? If the tics happen to be severe, like our first, mild, like our first patient, then we'll consider the CBIT, Guamfacine, Clonidine, and topiramate. Didn't really talk a lot about topiramate, but topiramate is another medication that can be used, and it's a anti-seizure medication that can be used for tics that happen to be mild. Going down a little bit further, if we find that those tics happen to have little or no benefit, then we can try some of the benazines. So tetrabenazine, duratetrabenazine, and valibazine. So those are some of the first-line therapies whenever it comes down to sort of mild or severe, mainly sort of tics that we're sort of trying to sort of deal with. If it's like our last patient, Giovanni, going back up, and they happen to be focal tics, that's where sort of Botox sort of comes into play. And oftentimes Botox will sort of remove those focal tics, especially if that happens to be that one that cycles and comes back and forth. Sort of going down a little bit further is the second line agents, which are generally some of the second generation antipsychotics. So these are the Abilifys, and this is sort of the area where I would use Abilify and Risperdal. It's a second line therapy, recognizing that it is quite helpful for tics, but we oftentimes are looking into the side effects that may sort of arise as we start to use these medications. And so monitoring these medications much more frequently, sometimes with labs, and then definitely trying to get much of your feedback or much of my patient's feedback whenever it comes down to using these medications and making sure that there's the benefit versus the cost. And that's sort of more of a medical cost of using those medications. And if you still get little to no benefit, our last sort of option for those refractory, difficult to treat tics that sort of lead to poor quality of life, poor activities of daily living is the deep brain stimulation. So now, as we sort of talked about tics, we've gone to tic clinic, we've talked about the different medication management, the reason why we choose those medications and some of the side effects and the doses of those medications. Let's talk a little bit about society and culture. So whenever we talk about Tourette syndrome, just wanted to sort of mention some very successful people that have Tourette syndrome, like Billie Eilish, the musician. You can see all of her awards there, and she's somebody that I listen to and happy to that she's, conquered her Tourette's and sort of happily vocalized the fact that she has it, as well as Dan Aykroyd. And so who, regardless of whatever desire that you can have your Tourette syndrome and still be somebody that's a public figure and somebody that is frequently seen, despite having, true stage fright that sometimes can make your Tourette's a little bit worse. Furthermore, whenever it comes down to other people that may be also sort of on a stage, but a different stage, where there's Howie Mandel that happens to oftentimes be sort of judging others, or previously a comedian and sort of a great person that vocalized and talked about his battle with Tourette's. And he also is somebody that is a Tourette's plus syndrome person that oftentimes also complains of his OCD. For him, it's sort of recognized in him with him also sometimes being a germaphobe. Another person is Jamie Grace Harper, which is our young lady here we have at the bottom. She has many of the other comorbidities. She has ADHD, she has OCD, she has generalized anxiety disorder as well as echolalia. And she happens to be a Grammy-nominated young girl that is sort of flourishing in her career as a musician. Above her, we have David Beckham, which is a well-renowned soccer star that also sort of tells you about his battles with OCD. And then finally, we have Mozart. And so everybody knows him as a composer and well aware of his beautiful music. And so just wanted to mention a few people that we all sort of have seen and or recognize their work that have both Tourette syndrome as well as OCD, at least. So here are my some of my resources. And now I say thank you. Thank you for your time. And now is the time for questions. If you have any questions, I presume that they are in the chat, and I will look forward to answering them. Or you can reach out to me at my website, email, or at the office. Thank you.
All right. Thank you, Dr. Heard. We really do appreciate you taking the time. So we do have a bunch of questions already out there, so give me a minute to gather myself. Have you ever heard of a spitting tic?
A spitting tic? Yes.
Okay.
So, yeah, so once you get to,
Go ahead, finish.
So once you get to the voice box, I mean, those tics can be a little bit of everything. And so it could sort of result in sort of spitting or some tongue thrusting. Those are some of the common ones that some people will admit to.
Can you speak to the success rate of habit reversal therapy?
The success rate, it definitely depends on the timing. So just as we sort of talk about the waxing and the waning of the tic, if you can go to habit reversal therapy at the same time in which you are having a sort of more severe timing of the tic, in which your urge is oftentimes used, you can find that the habit reversal therapy is quite helpful. And sort of can get you from this wax period to sort of go to the waning period, not too far afterwards.
Okay. Is disinhibition and emotional overload and rage part of TS, or does that get associated with ADHD, and does it matter at all where it's categorized?
It doesn't really matter where it's categorized. I was trying to sort of reiterate the fact that the myriad and the spectrum of illnesses in the alphabet soup, whether it's TS or ADHD or OCD or generalized anxiety disorder or sort of behavioral impulsivity, it's the impulse. So all of these are along a spectrum of different types of impulses that manifest in different ways, whether it's a motor tic or a vocal tic, whether it's anxiety, whether it's OCD behaviors. It's sort of the impulse that happens to be sort of the foundation of sort of all of these things.
What are the therapies recommended for disinhibition and or emotional overload?
Some of the same therapies, to be honest with you. Whenever I have a child that comes in with impulsivity and they sort of can't sort of inhibit themselves from doing some of the things that are inappropriate to their environment, I usually do start off with Guamfacine or Clonidine, and oftentimes we'll sort of increase to a possible antipsychotic second generation, depending on their current response and or side effects. That's a large portion of my job, is just trying to make sure that we can balance between the benefits and the side effects to make sure it's tolerable.
Do medications affect how CBIT therapy works? Does it make CBIT less effective?
No, it doesn't make it any less effective. I mean, I think that a large portion of it is practice and timing. And so the medications may sort of take the tic completely away to where the CBIT may not even be necessary. But you can do the combination of both. And I usually sort of allow that combination to be what is true for any behavioral. So whether that's ADHD, sometimes behavior modification is enough. Sometimes you need behavior modification and a medication. And so this is no different.
Okay. With the alpha agonists, alpha 2 agonists, do you suggest it in combination with methylphenidate, or especially with kids with emotional overload symptoms?
Yeah, so I will do both. So for my kids that really have a hard time with their ADHD and they really feel they need the stimulant, I do sort of warn against all of the side effects. So the stimulants are, phenomenal for being helpful for ADHD, but oftentimes can make the tics and the Tourette's worse. It oftentimes can lead to more emotion lability to where they sort of have a letdown. I oftentimes will compare the stimulants to coffee. For those that drink coffee, whenever you have too much coffee, you tend to be a little bit more on edge. You tend to be a little bit more snappy. Instead of when responding to your name with a hello or yes, you may sort of respond with a little bit more snappy, like what? And oftentimes that's some of the side effects that come along with the stimulant. And so sometimes I do have kids that are on the stimulant, methylphenidate or dexamphetamine, along with guanfacine, sort of as a polytherapy for treating multiple diagnoses. And so oftentimes the feedback is really what I'm looking for that, to make sure that they are have a better quality of life with both medications. But if I can get a twofer in, one medication for treating two things, that's what I usually try to do.
Okay, twofers, they're always good.
I agree.
Would TMS be helpful for Tourette syndrome?
With TMS? Yes, TMS has been helpful for Tourette syndrome. And so it's not very many centers. At Boston Children's, we definitely did TMS. And so it's not very many centers that do TMS sort of regularly for it to be something that is as mentioned. I could have mentioned it here, but yes, it is something that has been used for TS.
What would you suggest for someone who has mainly vocal tics?
So oftentimes for the vocal tics, I have found that like the habit reversal therapy is oftentimes helpful. Trying to find a functional sort of voluntary movement. And I found for many of my kids that have the vocal tics is sort of trying to sort of make their tongue go to the roof of their mouth has been sort of the voluntary movement that has been helpful for many of them.
Okay. What percentage of your patients have received DBS or deep brain stimulation?
So I haven't had any patients that have required deep brain stimulation. So deep brain stimulation, it's something that is fairly been going on maybe the last 10, 15 years. It sort of started off in the older population, mainly for movement disorders that went along with Parkinson. And then it sort of has come down to Tourette syndrome. And oftentimes I haven't necessarily found someone that's that refractory and sort of hasn't responded to medications. Again, the environment of bullying and a huge amount of social distress may sort of get us to that refractory nature, but usually my medications are usually enough for them to sort of not necessarily need to have to go that far.
Okay. How does regular Guamfacine work compared to the extended release of the same medication?
Yeah, so it depends. All of these medications depend on your metabolism. Whenever it comes down to taking the Guamfacine, we give it at night because of the sedative effect of it. And then it should work through the majority of the afternoon. And so if we sort of start to notice that they do well during the majority of the functional day, so during the majority of the school day, and then at home they have multiple tics but not bothersome to their environment, then we can sort of say the Guamfacine sort of has been fully metabolized in their system by 4 o'clock. However, if after 4 o'clock they sort of have multiple clubs and sports and they still need to have that management, then we'll sort of either make it twice a day dosing or we'll change it to extended release. And again, I'm looking for the feedback to say, okay, we gave it in the morning, we're not sleepy, we're still able to function during our school day, and then it actually lasts through baseball practice, choir, theater, to where it's not a bothersome during the evening.
Okay. Do you have, what are your thoughts on Pandas in children and adults?
So Pandas generally is a very controversial sort of illness. At Boston Children's, I definitely have seen kids that have the combination of having a worsening of their tics in the setting of a strep infection. But it's something that has a hard time knowing when to stop. So you can continue antibiotics. Some of these kids, legitimately do get better on antibiotics, but antibiotics for a long period of time does have its fair share of consequences. And another sort of mainstay treatment is steroids. Equally put, long-term steroids can have its fair share of consequences. And so it's very controversial because it's hard to know when to stop those treatments and how to balance the side effects that may come along with it.
Okay. So there's a child who was diagnosed with TS at age 7, but now at age 12, ADHD symptoms are getting in the way with an emphasis on the attention and memory, not so much the hyperactivity. Off-label medications haven't seemed to work. And traditional ADHD meds have been too stimulating. It's been a number of years since they've retried medication. So when would retrying medications give better results?
So usually I'll try to retry medication sort of after a cycle of life. And so to me, a cycle of life is sort of after 3 or 4 years. And we may be able to retry whether it's a stimulant. I'm not sure if all of the different categories of stimulants have been used, the amphetamines or the methylphenidates. And then there's 3 different types of majorly used non-stimulant options. That's the Guamfacine, there's Clonidine, there's Strattera, and trying to see if any of those medications with different mechanisms of actions may be helpful for treating their ADHD.
It is 8:30. What I'm going to say is we are going to stay on and continue to answer some questions because we did start a little late. And Dr. Heard, you can tell me when you're done, or I will stop it at a certain point. So thank you everybody who's got other things going on during this time and needs to jump off. We appreciate that you came on. Don't forget to fill out the survey. And now we're going to continue on with questions. patients with TS and ADHD, we were just talking about that. What's your preferred neurostimulant?
I usually try to do the dexamethylphenidates, and so this is usually Focalin. I usually will start off with the immediate release formulation, and then once we sort of get a general idea about their metabolism, how long it stays in their system before it comes out, and if they are able to deal with some of the side effects, then I'll sort of graduate them to the extended release to improve compliance.
Okay. What's the dosage of Abilify that generally works in teenage girls?
Depends on the girl, and again, it oftentimes depends on the metabolism, but usually about 5 milligrams is sort of where I sort of start, and then we can sort of go up from there. Oftentimes I'm worried the higher the medication dose, the more likely the side effects of increased weight gain and the possibility of the metabolic syndrome that I spoke about before.
Has Bonfiscene ever been known to cause anxiety in teens?
Not necessarily known to cause anxiety. It's actually the medication that I use whenever somebody experiences anxiety with any of these other diagnoses. So ADHD and anxiety, impulsivity and anxiety, Tourette Syndrome and anxiety. I usually choose Guamfacine because it's a little bit more calming without removing their personality, which can sometimes be true in some of the other medication choices.
Since antipsychotic meds can cause tardive dyskinesia, how can we tell the difference between that and their tics?
Yeah, so tardive dyskinesia usually is caused by the medication. So again, remember, Tourette syndrome happens before the age of 18. Tourette syndrome is not something that that is caused by a medication. Generally, before the double digits, they have seen these tics. The tardive dyskinesia is usually after you've been on one of these antipsychotics for years. And so that's usually how you can sort of identify the diagnosis of Tourette's versus tardive dyskinesia. The tardive dyskinesia usually, unlike Tourette's, starts in your mouth. So they'll sort of play with their mouth a little bit more often, pucker their lips, play with their lips a little bit more often. That sometimes is an issue. And then there's a little bit more of a tremor aspect to it. Whenever I think a little bit more about tics, they sort of can be purposeful appearing movements that happen to not be purposeful.
Okay. So when Abilify causes the significant weight gain, but is all that has worked up to this point to control rage, impulsivity, and explosive behaviors that are comorbid with other tics, what do you tend to try next?
So I may end up trying a different type of antipsychotic and see if that may possibly be helpful. I didn't really talk about like tetrabenazine, which is more used for movement disorders more so. So the motor tics. So I may sort of try to see if I can go backwards to tetrabenazine and see if that happens to be helpful, because that's not a common step. Usually it's the alpha agonist down to the antipsychotics. And so tetrabenazine has sort of been around a little bit more in between the creation of the first generation antipsychotics and the creation of the second generation antipsychotics. So I would try tetrabenazine with a different mechanism of action without those side effects to see if that possibly could be a solution for them.
Okay. What's the maximum dosage of Guamfacine that can be used in an adult with TS?
Adults is a little bit, outside of my realm a tad bit because I do peds. However, it's usually sort of based on side effects. There's oftentimes a general range, and this is how we sort of operate in medicine. There's a general therapeutic range that exists, and that range is dependent upon side effects. I have seen Guamfacine sort of used up to 6 milligrams. Again, these are in kids. So as we sort of get to 18, 18-year-old can be as large as a 25-year-old or what have you. So it sort of depends on the side effects. So if we go up to, I'm making this up, 10 milligrams, and they happen not to be sleepy, then we would sort of continue to monitor and watch. Guamfacine is in the category of an alpha-2 agonist, which initially was used as a hypotensive medication or medication that's used for hypertension, and it can lower your blood pressure. So that would be something else that I would notice to pay attention to a little bit more in adults that I really don't see a lot in kids.
My 16-year-old is not aware of the premonitory urges at this time. Would habit reversal be even worth trying?
Not fully, because you really need to have that urge to practice the urge with the involuntary movement, sorry, with the voluntary movement. And so without that urge, habit reversal therapy may not be helpful. However, habit reversal, as I said, is under the umbrella of cognitive behavioral interventions. And so you can do the other things, relaxation techniques, removing some of the environmental issues that sort of cause the tics to become a little bit more predominant, and that would be helpful.
You can email info@njcts.org if you live in the New Jersey area. We have lists of cognitive behavioral intervention therapists or people who've been trained in it. How's that? For the tic treatment you mentioned, Abilify being one of your go-tos. Please elaborate.
That's if we get down to the antipsychotics. My initial go-to is usually the alpha-2 agonist, and that would be the Clonidine and the Guamfacine. Usually go to the Guamfacine first, just because it happens to be a little bit more benign, a little bit more easily tolerated, and does have that extended release option.
Okay. Do you think neuro or biofeedback be helpful for TS?
It can be, but I will say that it depends on who's offering it. And so it's something that happens to be controversial. Sometimes multiple sessions are needed, and it can be a little bit expensive. It's not always covered by insurance. If you find it to be helpful, go with it, but it's not something that I can easily and readily say that is also always going to be the best bang for your buck.
Do you feel genetic testing for medications is useful or beneficial for treatment?
Yeah, so pharmacogenomics can be helpful to give you a general idea of what I sometimes am asking during my feedback sessions. It lets us know what you metabolize well, what you metabolize quickly. And so, like I say, I usually sort of start you off in somewhere in that therapeutic window. And so if this is a window, you sort of start off here for me. You can sort of advance somewhere in between that window, but pharmacogenomics may let me know that you are a slow metabolizer. So because you're a slow metabolizer, it means you hold on to the medication for a long period of time, and you're going to need a lower amount of that medication. If you're a fast metabolizer, then it's going to be very easy for you to quickly get to the upper end of that that window. It's helpful, I think, more for your for the mental health piece of it. Sometimes if you're a fast metabolizer and we're having to go up on the dose, you would recognize that it's not because I'm refractory or it's a more severe case. It's just because I'm not going to respond until I get to this higher dose, and I think that that's helpful.
Have you ever treated TS with an SSRI or SNRI?
Yeah, so oftentimes I use SSRIs or SNRIs. Thanks for mentioning that, especially whenever the anxiety is an issue. It sometimes takes a longer period of time for you to get that effect, and that's why I didn't really mention it here, because SSRIs and SNRIs usually take 4 to 6 weeks for you to get that optimal peak effect. And oftentimes you're coming to me because this is something that's bothering you, on a day-to-day. And so for me to say that I'm going to give you this medication and 4 to 6 weeks is whenever you're going to start to receive some of the benefit. I usually would like for that benefit to happen sooner rather than later. And so that's why the SSRIs are the ones that I use initially. But if you happen to already be on an SSRI, then usually I'll try to sort of advance it by going up on it to try to see if I can get you some sort of relief and or treatment sooner rather than later.
Okay. You haven't mentioned Trokendi. Our doctor prescribed this. Have you used this before with Tourette syndrome?
So Trokendi was sort of mentioned when I talk about topiramate. So topiramate and Trokendi, they're sort of in the same family, they're cousins. So topiramate is the initial sort of first molecule that's sort of used, and then Trokendi, there's another one that it has a little bit of a difference with the extended release formulation. That's where you get the name Trokendi. Topiramate, Topamax. Those are all sort of the same family. So I do use those. They also have some side effects that sometimes are a little bit harder to understand in the population that we're using these kids. Sometimes Topamax can cause you to have some mental fogging or some mental dullness that sometimes the younger kids may not necessarily know how to identify. So I'm sort of very choosy on the kids that would be able to identify that, to make sure that they're going to give me that feedback that they have some cognitive difficulties that they recognize after being placed on the medication.
Okay. Have you seen hypothyroidism associated with TS, or is my son, who's been battling now for 6 years with TS, just the lucky one who happened to have it masked by his symptoms?
It's not a common association. So hypothyroidism is what they were saying, right? Hypo?
Yes,
Yeah.
hypo. Yep.
Yeah, so hypothyroidism sort of usually results in sort of other manifestations that's usually not movement related. So usually they have a slower metabolism. Sometimes it results in weight gain. Sometimes they have some mental fogging, mental dullness, changes in their skin, difficulty with their metabolism to where, you know, that's where the weight gain sort of comes from. But it's sort of having its association with Tourette's. I wouldn't say that that was a correlation that is common.
Okay. I'm not sure what they mean. This question says, is it possible to get rid of TS through surgery? And I'm assuming that means deep brain, because that's the only surgery I know.
Yeah, so it is possible. I'm hoping that there are other medications that can get there before the deep brain stimulator is needed. But it's not a change on the brain that is a structural change. If you remove that area, like we can sometimes do with epilepsy, it's not a area of the brain that you resect and cures you of your TS, if that's what they're asking.
Okay. Do you recommend taking Abilify at night or in the morning?
Abilify usually makes you a little bit sleepy, so I usually would say take it at night. And then sort of depends on your sort of metabolism as to if it sort of can wrap around to the next day to give you the benefits of it during the day.
Okay. Well, I think this is a good place to end our questions. Any questions that were posed that did not get answered tonight, I will put on our blog, and you can go to our website at www.njcts.org under programs, and you can find the blog. So I appreciate you taking the time, Dr. Heard, for planning this webinar, retooling it, and helping us out tonight on medication management. So thank you for joining everyone. Thank you for joining our webinar on medication management in Tourette syndrome and co-occurring disorders. There is an exit survey, which we need everyone attending to fill out, and the webinar blog is now open and available for the next 7 days on the NJCTS website for any additional questions not covered in tonight's presentation. Also, an archived version of this webinar will be posted to our website as well as emailed to all the participants. So our next presentation is attentional and neuropsychological difficulties experienced with epilepsy. Surprised you're not doing that, Dr. Heard. It will be presented by Dr. Hillary Murphy and is scheduled for June 1st, 2022. This ends tonight's webinar. Thank you, Dr. Heard, for your presentation. Thank you, everyone, for attending. Good night.
Bye-bye.